When I first started learning about supervision, it was outside of the field of speech pathology, and there's one organization or group of organizations that I worked with that followed this apprenticeship model that actually rang true when I got to a medical setting. There's this joke in medical settings and medical TV shows even where this idea that a doctor, they see one, do one, teach one, right? That like they observe it once and then all of a sudden they're doing it. And the minute they're doing it, they're already teaching kind of the more junior clinician on their team how to do it. Well, while that can be a joke, and to a degree it is, there's also a more pedagogically sound version of that, which is this apprenticeship model that is true outside of medical professionals as well, right? Where you start at the beginning with I do and you watch, and then you talk about it afterwards. How did it go? What did you notice? And then as somebody gets more comfortable, the supervisee gets more comfortable, you move into I do, you help, we talk. You do, I help, we talk about it. And you do, I watch, and we talk about it, right? And the we talk is really essential for growth in this apprenticeship model, that as you are kind of relinquishing control of a clinical skill or a task, that there's this ongoing discussion. And what I love about this version of the apprenticeship model that's listed here is that there's this reminder about the fifth level, which is when you as the supervisor are completely pulled from the situation and the supervisee is doing, and someone else has become the supervisee or the watcher, right? So this you do, someone else watches place where you can kind of grow your ability to impact the field by working with a lot of students or novice clinicians, and then they become the experts at some point in the future. And hopefully, at least with some of them, you're able to maintain some kind of supervisory role or mentorship role over the long term, where that we talk is still the original dyad, right? Where people can come to you for advice about their own future situations when they become the clinical instructor or the person who is apprenticing the next level of clinician. So the idea here is that based on your situation, you're going to ask different types of questions. And the way you figure out your situation is thinking about what you have in front of you. So what level your learner is at within this specific task, the urgency of their independence and autonomy in this scenario, and also what the actual task is. So when we talk about the learner, I'm just going to push forward to here and then we'll come back to the rest of that slide here in a second. When we're talking about the learner, at each level of this in the SQF, things get numbers. And so in the SQF model, instead of having 4 phases from that conscious competency model from the 80s, we've now squished this into 3 phases. So all of our incompetent students fall into the D1 level of learner, or the developmental 1 phase, where they are, needing a lot of support, and then they move into D2 and D3 as they gain that competence and the unconscious competence or the automaticity of what it is that you're teaching them. And remember, again, students aren't going to be, always a D2. They might be a D3 in one area of their clinical practice and a D1 in other areas of their clinical practice, right? Okay, so back to this page here. So you're going to take whatever level learner you have and then think about the urgency. What is the time frame in terms of how much pressure is there? How quickly do we have to learn this specific skill? And what are the consequences of doing it poorly, right? So if I have a student who's a D1, or maybe even let's say we have a D2 level learner, and we're working on swallowing evaluation in fluoroscopy, where if the student is left to their own devices and does it wrong, then there's a really strong consequence of danger of aspiration of barium, or not getting all the diagnostic information we need. That's going to change the type of questioning or feedback you provide, right? And then the task level. So is this a novel or novel task or familiar to them? How complex is it? And again, what are the consequences of doing it inaccurately? So you first have to kind of determine what situation you're in. Then, based on the situation, you are going to provide different levels of supervision. Okay, so this requires you as the supervisor to use a style that matches the needs of the learner in each given situation. So there are 3 different types of supervision that you can provide based on which situation you're in. Moving on from kind of that initial conversation with your student, we think about kind of the day-to-day experience of having a student or another type of supervisee in your clinical setting and sharing your job with you, right? And in that, I often get asked, well, how much supervision is enough supervision? How much of the day do I need to be spending one-on-one with my student? And what a type of productivity can I expect from them? And what type of supervision do they need during that productivity? And it's very much going to change from one type of supervisee to another. So just to give you some examples here, so SLP assistants, this list over on the left-hand side of this slide, comes from ASHA's recommendations. These are not necessarily perfectly regulated in every of the 50 states. There may be state-specific expectations that are different than this, but just going off of ASHA's advice, when you're working with an SLP associate of some kind, the idea of how much supervision is enough includes within the first 90 days of their time, they're going to spend more than 30% of their time needs to be spent with you. 20% in direct, like with the client present, and 10% in indirect supervision. And then within that first 90 days, you need overall more than 20% of the actual client contact time from a week-to-week basis needs to be with the supervisor present. So the other piece of advice here is that all clients need to receive some direct contact with the SLP at least once every 2 weeks. And so you need to be scheduling your supervision time, both direct and indirect, to meet all three of those bullet points within that first 90 days. After 90 days, the expectation from ASHA's level has been that more than an hour of direct supervision be provided on a weekly basis, and that direct supervision be provided for each client at least once every 60 days, rather than talking about the kind of within each 2-week period. That varies drastically from the ones listed on the right-hand side of this stage, which are varying levels of training towards working with somebody that has their master's. Self-assessment as a clinical supervisor is thinking to yourself about what do you have in terms of knowledge and skills, and what do you need in terms of knowledge and skills specific to clinical instructing. Though you certainly should also be providing that own self-assessment to yourself about clinical delivery. I want you to focus just for today on the clinical supervision piece. Okay, so one of the greatest ways to do this, and I love this tool that was put out by ASHA. So this self-assessment tool was one of the deliverables that was developed by ASHA back in 2016. There was an ad hoc committee on supervision training, and the goal of this document that they produced was to assist all audiologists and speech-language pathologists that were providing supervision to graduate students or other supervisees in conducting self-assessment of their knowledge and skills. The tool was intended to be used to kind of self-rate competencies and to develop your own goals for training in order to improve your abilities as a clinical educator, a preceptor, a mentor, a supervisor, whatever terminology you want to use, right? So one of the additional recommendations made by the 2016 ad hoc committee is that this self-assessment tool that I'm about to tell you about would also be used as a continuing education tool. And so speech pathologists and audiologists had a more formal opportunity to self-reflect, plan, and individualize competency areas when they were preparing to do supervision and what training they need before they deem themselves a competent supervisor.